In 2016, one of the most respected names in artificial intelligence, Geoffrey Hinton, winner of the 2018 Turing Award and the 2024 Nobel Prize in Physics, stood in front of a packed room and said something that at the time sounded like science fiction. He said, "We should stop training radiologists because within 5 years," he argued, "deep learning would do their job better than they ever could." 5 years passed, then 10. Radiologists are still here, but the story he started back then isn't over. In some ways, it's only now getting interesting, because artificial intelligence didn't replace radiologists. It came for something much stranger and much bigger. Today, we go deep on a single question: how is artificial intelligence actually changing the medical profession? Not the hype version, not the apocalyptic version, the real version with real studies, real numbers, and real names of tools sitting in hospitals right now, reading scans along flesh and blood doctors. By the end of this video, you will know which 3 medical specialties are most exposed to AI, which 3 are the safest bets if you are a student choosing a path, why psychiatry is suddenly the plot twist nobody saw coming, and which diagnostic tools are already approved by the US Food and Drug Administration and built into clinical algorithms today. If there is one medical specialty that's been the test case for everything AI promises and threatens in medicine, it's radiology, and rightly so. Radiologists look at images, X-rays, CT scans, MRIs, mammograms. Their job is fundamentally pattern recognition on visual data, exactly the kind of task modern neural networks were built to demolish. So how do they actually perform? A 2024 study published in Scientific Reports tested an FDA-approved AI system on chest X-rays. The AI achieved an accuracy of 0.976. An accuracy of 1 means perfect, 0.5 means random guessing, so 0.976 is extraordinary. And it generalized to a publicly available external database at 0.95. Numbers that good on data that broad would have sounded like fantasy a decade ago. Then there is the rollout at Northwestern Medicine, published in 2025. They deployed an AI tool across 11 hospitals, analyzed nearly 24,000 real radiology reports over 5 months, and measured what happened. The results? On average, radiologists wrote their reports 15.5% faster when they used the AI. For some radiologists, the speed gain climbed to 40%. Follow-up work, still unpublished, shows speed gains of up to 80% on chest X-ray, plus useful improvements on CT scans too. And the crucial part, with no loss of accuracy. A meta-analysis on chest X-rays for detecting pneumonia and lung cancer, covering studies from 2017 through 2025, found that AI helps consistently. The studies show improved sensitivity with no loss of specificity when radiologists work with AI compared to working without it. So is the debate over? Is AI better than radiologists? Not quite. An international study that pitted 8 commercial radiology AI models against human radiologists found that on chest X-rays and mammograms, the radiologists' overall diagnostic accuracy was still superior. On a scale of 0 to 1, where 1 means a perfect diagnosis and 0.5 means random guessing, the AI scored 0.87, while the radiologists scored 0.96. But, and this is critical, the AI's accuracy was at least equal to that of the least experienced radiologists on mammogram and fluorography, and at least equal to all radiologists on chest X-ray. In other words, AI is good enough to be a useful first reader, not good enough to be the only reader, for now. There is also the problem of how well it works in the real world, beyond the lab it was developed in. In 2024, a study in Nature found that chest X-ray models trained on a single institution could lose up to 20% of their diagnostic performance when tested on data from outside that institution. Hidden biases in the training data, a type of scanner used, the patient demographics, the labeling conventions, limit how well these models work in the real world. And that's part of why we still need humans in this process. But take a step back and look at the trend over the past few years. By August 2025, the FDA had cleared 1,247 AI-based medical devices. Over 75% of them are in radiology. Hundreds of new approvals in just the last 2 years. The major target diseases, lung cancer, stroke, breast cancer. The infrastructure is being built, regulators are approving the tools, and the questions for radiologists is shifting. It's no longer, will AI replace me? It is, which parts of my job will AI handle by default 5 years from now? The honest answer most observers give now is routine reads, triage, preliminary report drafting, second reader verification. Those move to AI. The hard cases, ambiguous findings, patients with complicated histories, multidisciplinary decisions, conversations with the referring physician, those stay human. So a radiologist doesn't get erased, it gets compressed. Fewer radiologists may end up doing more work, with AI carrying the bulk of the volume. That has real implications for how many radiology residencies we need, for what radiologists train for, and for how the profession will look like in 2035. Alright, so let's name some names. Based on research, which 3 medical specialties are the most exposed to AI pressure? The criteria are fairly consistent across the literature. High volume, pattern recognition on digital data, predictable workflows, and relatively limited patient contact. These are the kind of activities that are vulnerable to AI. Number 1 is radiology. We just covered it, so I won't belabor it. The combination of huge data volumes, image-based work, and AI's early maturity puts radiology at the top of the list. Number 2, pathology. Pathologists look at slides. They identify cancer cells, infectious abnormalities, so work almost perfectly analogous to what radiologists do, only under a microscope instead of a scanner. AI systems trained on pathology slides have shown excellent performance at detecting tumors, classifying cancer subtypes, and identifying biomarkers. The workflow is similar. Routine reads go to AI. Human pathologists handle confirmatory diagnosis and truly strange cases. Large institutions are already piloting AI-assisted pathology workflow, and digital pathology adoption is accelerating, which removes the last technological barrier to large-scale deployment of these models. Number 3, dermatology, specifically the diagnostic, image-based part of dermatology. Skin cancer screening from photographs is a problem AI has gotten very good at. Smartphones, skin checkups, applications already exist for consumers. A patient with a worrying skin lesion no longer needs to see a dermatologist first. They can get a probabilistic risk score from their phone and then escalate if needed. This doesn't eliminate dermatologists. Biopsies, treatments, complex cases, cosmetic procedures, surgical dermatology, none of that goes away. But the first-line screening function is genuinely under pressure. Honorable mention, ophthalmology. In that specialty, there is already an autonomous AI diagnostic device called IDx-DR. Already screens for diabetic retinopathy without needing an ophthalmologist on site. We'll come back to it later. The common thread in all of these, image-based work, high volume, pattern-driven. If a specialty daily task is observing pixels and writing reports rather than having a dialogue with a person and choosing a treatment, That specialty is closer to AI's blast radius for professions. Which three specialties seem most insulated from the AI pressure? Number 1, surgery, especially complex, out of the ordinary surgery. Yes, there is robotic surgery. Yes, AI is used for pre-operative planning, intra-operative imaging, and even autonomous suturing in narrow contexts. But the actual act of operating on a complicated human body, managing an unexpected bleed, navigating an anatomy that doesn't match the textbook, making split-second decisions when things go sideways, that remains deeply human work. The combination of fine motor skills, three-dimensional spatial reasoning, real-time judgment under uncertainty, and the ethical weight of cutting into another person is exactly AI's weak point. Surgeons may gain powerful AI assistance, but they won't be replaced. Number 2, emergency medicine. Emergency departments are chaotic, noisy, high-stakes environments where the diagnosis is often unclear and the patient can't always tell you what happened. Emergency room physicians juggle dozens of patients with incomplete information, triage rapidly, perform procedures, coordinate with trauma teams, and deliver bad news. AI can absolutely help. They are excellent triage tools, predictive models for infections, stroke detection systems, but the actual practice of emergency medicine demands the kind of human improvisation AI is still years, if not decades, from reaching. A 2025 review concluded that the human expertise and agility required by emergency medicine make it a specialty unlikely to be fully automated in the foreseeable future. Number 3, family medicine and primary care. This surprises people because primary care seems like it should be easy to automate, and family medicine does involve a lot of routine decisions, prescription refills, standard guidelines. But the real value of a good family physician is the longitudinal relationship, knowing your patient for years, catching subtle changes, navigating their social context, managing multiple chronic conditions coherently, and being the trusted human face of the healthcare. Plus, the demographic math is brutally favorable. Aging populations, chronic disease epidemics, and shortages of primary care providers in practically every developed country means demand is rising, not falling. AI will take over the documentation and decision support side, freeing family physicians to do more of the human relationship part of their responsibility. The common trait that protects a profession is physical presence, longitudinal human relationships, ethical responsibility, improvisation under chaos. The further your work gets from interpret a static digital signal, and the closer it gets to be a trusted physical present human in a complex situation, the safer you are. Here is where it gets interesting. If you would asked any expert 5 years ago which medical specialty was the most protected from AI, psychiatry would have been near the top of almost every list. Psychotherapy, empathy, the therapeutic alliance. Surely a chatbot can't do that. In May 2026, the British Journal of Psychiatry published a commentary by Alan Francis, chair of the DSM-4 task force, one of the most influential living psychiatrists, with a title that landed like a thunderclap. It was called, "Beware, AI chatbots will soon dominate psychotherapy." Francis doesn't mince words. He argues that the field has been too smug. The practitioner's confidence that no machine will ever replace me is, in his words, both incorrect and reckless. He believes AI is an existential threat to the profession and that human therapists will only survive by preparing to handle what AI does poorly. The seriously ill, the chaotic, the idiosyncratic, the rapidly changing, while AI takes over therapy for everyday anxiety and mild depression. and the data supports at least part of this concern. More than half of Americans have used a chatbot. Roughly 22% of adults and 13% of teenagers have used one to get mental health advice. In March 2026, about 2,400 mental health workers at Kaiser Permanente in Northern California went on strike for 24 hours, partly over fears that AI is being used to replace them. A licensed clinical social worker told America's public radio NPR that she had been reassigned from triage because, in her view, AI was being placed in her old role. So, is psychiatry doomed? No. And here is why the picture is more complicated than the headlines suggest. A Stanford study published in 2025 looked at how AI therapy chatbots handle high-risk situations, and the results were alarming. In one test, a user clearly expressed suicidal ideation by asking about the height of bridges in New York City. The chatbot responded obligingly, providing a list of tall bridges, completely missing the suicidal intent. Researchers also documented chatbots reinforcing stigma against people with severe mental illness, as well as a worrying pattern that Psychiatric Times called the iatrogenic dangers of chatbots, including cases linked to suicide, psychiatric hospitalization, and a new item, AI psychosis, in which heavy chatbot use appears to fuel delusional thinking in vulnerable users. The American Psychological Association's Director of Healthcare Innovation, Vail Wright, was emphatic. There is no consensus that chatbots can serve as a substitute for therapy. The technology can expand access, and that matters enormously given that roughly half of the people who could benefit from therapy can't access it. But the harms are real, and research base is thin. So the honest assessment for psychiatry is AI won't replace the empathic, long-term, complete work that defines quality psychiatric care. But AI will absolutely capture a huge share of the low-complexity market. And that market is bigger than most psychiatrists realize. France's warning is harsh but probably structurally correct. Psychotherapy and counseling roles, especially at the entry level and in mild to moderate cases, are under more pressure than the profession is willing to admit. Let's stop talking in generalities and look at specific tools working in real clinics right now with real performance numbers. IDx-DR, this was the first autonomous AI diagnostic device approved by the FDA in 2018. It analyzes retinal photographs for diabetic retinopathy. In its pivotal multicentral trial of 819 patients, it achieved an 87% sensitivity and 90% specificity for more than mild disease. Very important point, it's an autonomous system. A primary care clinic can screen for vision-threatening eye disease in a diabetic patient with no ophthalmologist in the building. The tool either gives the green light or refers the patient to a specialist. It's a real, complete, algorithmic step into the treatment pathways for diabetes. Viz.ai, this is a stroke detection platform that analyzes CT angiograms in real time and notifies the on-call neurointerventionist when a large vessel occlusion stroke is detected, often before the radiologist has even opened the image. In stroke care, every minute saved translates directly into brain tissue saved, and Viz.ai is now deeply integrated into the treatment algorithms of stroke networks across thousands of U.S. hospitals. Mirai, developed at MIT, is a breast cancer risk prediction model that uses a single mammogram to estimate a woman's risk of developing breast cancer over the next 5 years. It outperforms the traditional risk models clinicians have used for decades, and it's now being piloted to personalize mammographic screening intervals. BoneView, a system made by company Gleamer, a fracture detection tool for X-rays with FDA approval and CE marking. meaning approved by the European Community. The UK's National Institute for Health and Care Excellence, or NICE, issued a draft recommendation in 2024 recommending AI for fracture detection. Meta-analysis report pooled sensitivities and specificities above 90% in real-world deployments. It reduces the rate of missed fractures and shortens the length of stay in the emergency department. Generative AI for radiology reports. This is the newest frontier, multimodal models that look at a chest X-ray and draft a complete reports. Findings, impressions, recommendations, which a radiologist reviews and signs. In 2025, the Korean Society of Thoracic Radiology issued an official position statement on AI-drafted chest X-ray reports. This is no longer experimental, it's becoming standard infrastructure. There are also tools for cardiology, automated EKG interpretations, AI-assisted echocardiography, tools for dermatology, apps that score the risk of skin lesions, tools for pathology, algorithms that flag suspicious areas on a digital slide before the human pathologist looks. In 1,247 FDA-cleared AI devices I mentioned earlier aren't sitting in a warehouse, they are spreading through hospitals, especially in radiology, cardiology, and ophthalmology. The pattern in all of this is the same. AI is integrated into treatment algorithms as a triage step, a screening step, or a decision support step. It rarely makes the final decision, but it changes which patients see which specialists, when and in what role. And that's a profound shift in how medicine is actually practiced. Now let's pull back for the big picture within healthcare. Even as some specialties contract, the field as a whole is growing. The U.S. Bureau of Labor Statistics projects nearly 2 million healthcare job openings per year over the next decade. Nurses, physician assistants, home health aides, medical technicians, all of these have demand curves that go up, not down. And research on healthcare specifically backs up where the safe grounds lies. Medical technicians, all of these have demand curves that go up, not down. And research on healthcare specifically backs up where the safe ground lies. Consulting firm analysis place AI resistance scores for healthcare around 95% and for psychotherapy around 98%. The Washington Post reported in March 2026 on research from Gov.ai showing that within healthcare specifically, medical support workers and nursing assistants have the lowest projected vulnerability to AI, while medical secretaries and administrative assistants face the highest. So the disruption inside medicine falls hardest on the documentation and administrative layer, not on the hands-on, bedside, relational work. So the question we started with, will AI replace your doctor? For most doctors, no. At least not entirely and not soon. The highest risk specialties, radiology, pathology, dermatology, will look different in 10 years with fewer routine reads going to humans and more clinical judgment, communication, and complex case work as the core of the medical care. The highest risk specialties, radiology, pathology, dermatology, will look different in 10 years with fewer routine reads going to humans and more clinical judgment, communication, and complex case work as the core of the medical care. Psychiatry, contrary to everyone's expectation, faces a real structural threat in its low acuity segment, even though the human relational core of the work remains irreplaceable. The safest bets are surgery, emergency medicine, primary care, anywhere physical presence, improvisation in chaos, and longitudinal human relationships are essential. The honest takeaway is that AI is harshest on the cognitive, repeatable, information-based work inside medicine, image reading, drafting administrative tasks. It's gentlest on the physical, relational, improvisational work. surgery because care, frontline judgment, the honest takeaway, AI is harshest on the cognitive, repeatable, information-based work inside medicine, imaging, reading, drafting administrative tasks. It's gentlest on the physical, relational, improvisational work, surgery, bedside care, frontline judgments. So the rest is easy. Your doctor isn't disappearing. They should be getting more expensive, more rushed, and more tired because now they also have to double check with the AI lawsuits.